So we're very excited today to welcome everyone to our discussion about data. The title of our session is Trust and Data, and we're going to be exploring really this intersection of trust and data, the big data that's out there in claims, et cetera, that's somewhat anonymous, and then the other data that we acquire through communications that we use to build trust. And we're going to be talking about in the context too of the research that we do here at National Minority Quality Forum and that we do in collaboration with all of you. So we're just really excited to be able to have this discussion today and have you join us. I wanted to make a few housekeeping points before we get started. First, I guess I should introduce myself. I'm Mary Stober Murray. I'm the Vice President of NMQF's Collaborative Action Networks. We are going to be having a moderated discussion today, as we do with most of the NMQF Friday webinars, but also there's opportunity for audience Q&A. So we ask you to put your questions in the Q&A part, not the chat part, at the bottom of your Zoom. Instructions there. And then also I want to let everyone know we are recording the session, as you just heard. So the recording will be available early next week, as soon as we get it done and posted to the NMQF YouTube channel. And I'll put links into the chat for that. So without further ado, I want to go ahead and introduce our panelists today. We are so pleased to be joined by Dr. Kevin Alexander. Dr. Alexander is an advanced heart failure trained cardiologist. He's also an assistant professor of cardiovascular medicine at Stanford University School of Medicine, and he has expertise in diagnosing and treating, I'm going to mispronounce it. I'm going to use the abbreviation first, ATTR, but the hard to pronounce name is transthyretin cardiac amyloidosis. And this is a critical yet underdiagnosed cause of heart failure among African Americans and the elderly. He's conducting extensive research to enhance our understanding of this condition with grant support from the NIH and the American Heart Association, among other sources, and we'll be talking about some of that work today. Jacob Sauch is Director of Social Media Analytics at Volt Lab, which is a digital media agency focused on social good. Jacob explores problems from a variety of perspectives and offers quantitative and qualitative frameworks for solutions and holistic insights. He's a dual degree social science graduate of West Virginia University with a minor in statistics. And then Taylor Stair may also be familiar to many of you on the call. He's our data analyst at National Minority Quality Forum. He works with our clients and working group members on index development in support of health equity, advocacy, policy, and operations, including ways to build more representative clinical trials. He's also responsible for overseeing much of NMQF's data infrastructure resources, and much of his professional experience is developing data pipelines in service of creating digestible, visual data products for end users. So we're really excited to have this discussion with everyone today. I'm going to turn it over in just a second to Dr. Puckrein to make some additional opening remarks, but I also want to welcome Brandon Garrett. Brandon, we started without you, and I tried to introduce the Friday webinar series, but do you want to say a few words?
No, thanks so much, Mary. I was running from one meeting to the next, and we know that our staff knows that I've been having issues with my laptop here, so I had to go from my phone. But now I'm sure you did a great job, and thanks for everybody to joining us on our Friday webinar. So I will turn it over to you and Dr. Puckrein.
Thanks. Gary, could you introduce why is data so important and how do we look at data at NMQF?
Yeah, so thank you, Mary. I'm really excited. You know, I'm a data geek, so sitting around and talking about data, I could do that all day long. The National Minority Quality Forum, our principal mission is about reducing patient risk. You know, we worked for a long time and continue to work on issues related to disparities and making sure that not just minority populations, but all populations get access to quality care. And as we look through the data and been working on this issue, the thing that we came to is that really healthcare is about managing patient risk, mitigating patient risk for hospitalizations, risk for emergency room visits, risk for disability, risk for mortality. It's a risk game. And when you understand that it's a risk game, you also understand that it's quantifiable. The risk is quantifiable. And that's the lesson that we've learned from the data, is that quantifiable means not only can you quantify what happened in the past, but with the data, you can predict the future. And that's kind of where the National Minority Quality Forum has been working. So we have been collecting health data now for about 20 years. We have a database of over 5 billion patient records. We collect data on about 160 million lives a year, covering over 72,000 different conditions. That we refer to as structured data. We are understanding what people are being diagnosed for, who's treating them, what do their outcomes look like. And we partner with a lot of patient advocacy groups, organized medicine, because the issue is data is expensive. It's expensive to manage, to store, to analyze, to use. And so what we try to be is, I tell everyone, we try to be like the statistician at the baseball game. We don't go down on the field and play baseball, but what we try to do is collect the data so people can play Moneyball, if you know the analogy, so that they have the data that helps them understand how our healthcare system is working and managing that risk. And that's the most important part of it, that we're using the data to manage risk. And the important part is managing patient risk. So much of our healthcare system is about managing financial risk that we get confused and lose sight of the patient. And that our argument is that the metrics and tools that we need to use have to be around outcomes for patients. The COVID experience really changed us as everyone else. We had the opportunity through some partnerships with Centene to launch a clinical study on COVID. It's a 5-year study on COVID. We collecting 5,000 participants. We have about 4,000 of them now. And we do metabolic panels on them, whole genome sequencing, trying to understand the impact that COVID had and is having on minority and rural communities. And we did that with federally qualified health systems in about 5 states. And that brought us really close to the action, if it will, because those FQHCs, they were doing the test, they were doing the vaccines, they were not using the therapeutics, unfortunately, but we understood a lot about them. And one of the real takeaway lessons that epiphany moment, if you will, for me, was that they were also dealing with a lot of disinformation in their community, disinformation about whether you should get tested, whether you should wear a mask, whether you should get vaccinated. I mean, the whole array of things. And it's said to me that one of our challenges is that we're not very good at translating scientific information to the American public, to give them usable information and information that they could use at the moment they actually needed it. And that led us into the world of social media. Be candid, social media to me was this opaque thing that was going on out there, but really did not engage in it. And I realized for NMQF to really go about its mission in terms of reducing patient risk, it needed to be able to talk more broadly to the general public. And so we developed something that we called AI HealthNet. The way to understand it, it is a network of microsites. And so the rough analogy, if you think of Facebook, Facebook is about people. we're about ideas. And what we're trying to do is take very, very complicated ideas, reduce them to very small bites of information that we put on a microsite that allows people to get that information when they need it through a search function, an ad that we may put out, some information on their cell phone, doesn't matter. And embedded in that microsite are links to other information. So if they want to have a deeper conversation, a deeper learning experience on a topic, we take them on that journey, but it's all self-driven, right? We're not imposing any ideas on them. We're not trying to hold them to a particular website. It's just there for the moment when they need it. But the thing that's really powerful about, I think, the way we are operationalizing this, it's all on one domain, one platform, right? And so what that means is that all of the microsites are linked together analytically, and that allows us to pull down information to learn who is looking for what information, how are they looking for it, what's that journey looking like? Because what's important about all of that is that it helps us find lookalike audiences. It helps us to find others who could use that information as well. And the additional piece of it is those microsites that we're putting out there are not all developed by the National Minority Quality Forum. Again, that Facebook analogy, we are allowing others to put microsites up on the network, and that allows us to help them find lookalike audiences, because now we're all sharing the data, all sharing the information. And the beauty of that, it allows us to start crowding out the disinformation. You're not going to get rid of disinformation, you have to crowd it out. And the way to crowd it out is with trusted voices, linked together, reinforcing the message, helping people to understand why you have to wear the mask, why you have to get vaccinated, why you can use those therapeutics. And it's repeating the message, and that message coming from trusted voices that surround people and protect community from all of that really malevolent disinformation that comes from both abroad and domestically. So we're really excited about this effort. And what adds to the power of it is we have all this other data that we can bring to bear here. We know down at the zip code level how many people have diabetes, that they're going to the hospital at this rate, or they're not taking their medications, or whatever it is. And when you combine that structured information with the ability to communicate, now we're entering into the 21st century. Now we're having the capacity to really help communities. And we think this is the way we're going to address health disparities, right? And mind you, I'm using that, what I would describe as that old term health disparities, because really what we're about is managing patient risk. And that's the power of what NMQF is about. And we're really excited about this because the big takeaway for me, and I'll constantly repeat this, is that we need to be able to communicate very, very complicated ideas to average Americans so that they don't get lost in the noise out there of disinformation that actually puts their lives at risk, that actually destabilizes our communities. And so we're hard at work at that. I get to talk about it a lot, but it's really our team and folks like Mary and Jacob and Taylor, who you're going to hear from, that are actually doing the hard work of making this happen. But we think it's the paradigm shift. We think we're struggling to bring the public health side of American healthcare into the 21st century and make it so that every patient who comes into the American healthcare system understands that the system is operating, and is in fact operating to lower their risk. So I'm very excited about this. As I said, we're all about the data. And this is a conversation that hopefully everyone will learn a little bit more about how NMQF is approaching these topics. So Mary, I'll turn it back to you.
Thank you so much, Gary. I mean, that's a really big vision, I think, that you've proposed and presented us with. So I'm going to start, let's start, if we're going to start with a big vision, let's talk about big data and big data sources. And I'd actually like to start with Dr. Alexander. What are the big data sources that can help us explore healthcare and health equity? What is it that you use in your research, and what's out there that we use to get started?
Sure. I mean, I think with a lot of other sectors in society, the data sources that we have in healthcare, really exploded over the last decade. So, for my research, I've kind of focused on more historic data sources. So that being hospital records, claims data. I did some more recent work using the Centers for Disease Control Wonder database, which records diagnostic codes on death certificates. So it's a way to understand kind of the burden of life-threatening diseases as it relates to geography, count, down to the county level, race and gender. But I think more and more, and I think Dr. Puckrein, it was a great segue. Yeah, I think there's other data sources through social media and other venues that I think will become complementary and help us really understand at the patient level factors that lead to disparities. So I think that there's kind of more traditional data sources more directly linked to clinical care, but there's more important complementary data as it relates to social media.
Thank you. And we're going to get into some of those as well. I'm going to come back to you in a second to ask you to give us an example of how you've been using the Wonder database. But Taylor, maybe you could talk about what is the data that we actually have through NMQF, and how is it structured?
Sure. Yeah. So NMQF has made very large investment in the Medicare and Medicaid data. So that's very much at the core of what we're doing, and we use that data for both academic research, but then also for the various indices that we've created, mapping chronic diseases down to the zip code level, and so there's a lot that can be explored within that data. So we have claims data, really anything, any condition where there's an ICD code, a CPT code for procedures, prescription data for Medicare Part D. That's data that we have. And then in addition to that as well, we have data on all the providers that are seeing these patients in these programs. And as mentioned before, these programs combined, are nearly 150 million Americans. So it's a very large, cut of the population. And in addition to those, we're always seeking to add additional data sources as well. So, we're very much interested in including census data, including social determinants of health data from various sources. There's a lot of that out there, but then also including data sets that include, sites, whether it's screening centers for cancer or whether it's clinical trial sites, overlaying that on top of the claims data for the various diseases we're tracking can be a very powerful combination. So yeah, there's a lot of data out there to work with.
There certainly is. And then Jacob, I'm going to ask you to talk about the other data, the social media data that Dr. Puckrein started to address as well.
Absolutely. I think that the theme that really underlies all of this is that we're building communities. And if you think about social media from the perspective of trust and building communities, but you're really getting at the core of these shared characteristics. So one thing that I want to kind of posit is that you could look at Twitter as a source of patient experience based on what they tweet about, for example. You could learn about maybe symptoms that they're experiencing on a regular basis. And if you take that information and you extrapolate that with other parameters, you might be able to derive some kind of machine learning model that could predict the outcomes for a particular disease, like rare diseases and somewhat obscure diseases such as ATTR, previously mentioned by Dr. Alexander. Another thing that I'd like to impress upon you is that when you're thinking about those communities, it's not necessarily about the size. One of the most important characteristics is the engagement within those communities. So we like to look at the number of followers, but have you thought about the number of followers of your followers and what that kind of does for you? So it's really a question of the quality of your community and the links in between them. Having 1 million followers is great, but if you have 1 million followers that don't really do anything for you, you're kind of limiting yourself in a variety of ways.
Thank you very much. And before we go off this more general topic, I think we also want to mention the caveat that all of these fantastic data sources also have limitations. And so maybe just if each of you could touch on one limitation to be keeping in mind with the different data sources that we're working with. And I'll start with Dr. Alexander.
Sure. I think for the CDC Wonder database I mentioned that collects diagnostic codes on death certificates, there's an inherent ascertainment bias, meaning the data being recorded is contingent on the input from the physician filling out that death certificate. And so if there's, particularly for rare or underdiagnosed diseases, there can be a decreased likelihood that someone recognizes that particular cause of death and makes it onto a death certificate. So there can be, I guess, inaccuracies or differences between the true cause of death and what gets recorded on the death certificate, which in some research, some of the research that I did on cardiac amyloidosis was actually helpful to study that disease, but it's important to keep that in mind when designing a study using that database. Thank
you. Taylor?
Sure, yeah. So another thing that we encounter, at times is completeness of data. It's interesting looking at both the Medicare and the Medicaid data sets. There are differences between the two. Medicare is sort of more of a centralized program, whereas with Medicaid you've got 50 plus different programs, and so it's not as centralized, and so there are known holes even within that data where certain fields such as income or even race in some cases, while they're typically greater than 90% populated, sometimes you do have gaps. And in particular, one thing we found when we mapped this data was in the Medicare or in the Medicaid data set for 2016, we saw that Arkansas didn't even show when we mapped it, and so that was kind of an interesting thing that we found. And so the completeness of the data matters. And I think of COVID-19 data as well. And there's been a lot of frustration about the fact that there's been really an inadequate reporting on the racial component to the testing and vaccinations at times, and that's been challenging when you're trying to dive into the data more. So the completeness can at times be problematic.
Thank you. That's very thoughtful, particularly I think the difference between different programs, right? Medicare and Medicaid, and how the data is collected. Jacob, can you touch on limitations?
One limitation of social media is that it really is the edge case for a proxy of measuring behavior. You're at the mercy of what data connector or algorithm that you're using to collect things. So you're going to have different collections from different sources and different services. So one issue is really harmonizing those in a common scheme, and then making sure that that interpretation to be consistent over time, and making sure that that interpretation answers the question that you're actually hoping it answers. For example, if you're tracking website analysis, you might be thinking that you're tracking individual users, but what you have to understand is that the unit of analysis is actually an IP address. So that changes the interpretation, for example. That's a device. It could have multiple users. It could have multiple accounts set up before it actually has that one-to-one correspondence between an individual's behavior and what's being recorded by my service.
Yeah, you make me think of a situation where my son and I were using the same iPad at one time. And so we would each get different kinds of advertisements. So he would get advertisements, for a woman of a certain age, and I would get advertisements designed for, a 10-year-old boy at the time. So you can just imagine what those things are. But that really goes to your point about it's a device, it's not a person at the other end of that behavior. So it's worth thinking about. Thank you for that. So let's get, now that we sort of have an understanding of kind of the big picture of the data sources that are out there and their limitations, let's talk about some of the applications. So I want to start with a clinical application, which is exploring underdiagnosis. And that's something, Dr. Alexander, you've been working at with ATTR. And I wonder if you can talk a bit about that, and what does underdiagnosis tell us about disparities, or what does it contribute to our understanding of healthcare disparities?
Sure. Well, yeah, I'll start with the last part of that. I think looking at patterns of underdiagnosis is important for helping to understand how we, as a medical community, can implement interventions to improve that disparity. And so these kind of studies can help you target where the bottlenecks or the biggest problems are and focus your attention there. For the disease I study, just briefly a little bit about it. So it's called transthyretin cardiac amyloidosis, and this is, I think for a layperson, make an analogy, it's like Alzheimer's of the heart. There's a protein that's building up in the heart, similar to what Alzheimer's does to the brain. And over time, this can cause the heart to get stiffer and lead to congestive heart failure and heart rhythm problems. And so it can be a life-threatening disease. This has been long thought to be a rare disease, but we're increasingly recognizing that this is just really underdiagnosed, particularly the transthyretin form of this disease. And it has a particular high prevalence in the elderly and African Americans. And so those are groups that historically I think are vulnerable to healthcare disparities and underdiagnosis. So kind of even higher risk group for this type of disease. So I do a range of research in cardiac amyloidosis, from things in the lab, so molecular studies, but then things at the population level. And so we wanted to just kind of understand, for this rare, incomplete understood disease, what are some of the patterns of disparities or underdiagnosis. And so for us, the CDC Wonder database was really helpful, because we just we did a simple query of looking at the reported amyloidosis mortality over time in the United States over the last 35 years or so. And we looked at the reported death rates by race, gender, geography. We saw some things that were consistent with what we would have hypothesized, that men and African Americans and older individuals had higher reported mortality rates, which is consistent with what we clinically knew about the disease. But what was particularly interesting was that there was huge heterogeneity in the reported mortality by geography. So when we looked at the state level, there's areas in the upper Midwest and Northeast that have much higher reported mortality rates than the rest of the country. And so, you could hypothesize that this is related to some kind of environmental factor or social factor that, is kind of hard to tease out in this type of data. But what our team thought was more likely the case in this scenario was that we're really seeing that ascertainment bias that I mentioned earlier, that in order for amyloidosis to make it onto the death certificate, the physician had to recognize that as a disease and put it on and enter that on the death certificate. So if you're not even thinking about amyloidosis, it's not going to make it onto the death certificate. So we looked further at the county level data, and what we found was even more striking pattern, that within the states, there was huge heterogeneity in the reported mortality. And once we started to look at the individual counties with the highest reported mortality rates, one thing that was consistent was that they were all counties near established amyloidosis centers. So over the last few decades, there's been a handful of amyloidosis centers of excellence. The oldest probably being Mayo Clinic and Boston University, which have been around for over half a century. And so counties around those two areas had much higher reported mortality compared to other parts of the country. And so I think that reflects a higher awareness around places where they had that, focus for looking for this disease, and highlights that we're probably missing a lot of cases in these other places. And, as good as those centers in Boston and Rochester are, they're probably not, detecting every single case. So, it shows you that we still have a long way to go, but that kind of data starts to show that there's certain areas that we can improve on. And by having more healthcare centers that are looking for this and raising awareness among physicians, I suspect that will lead to improved detection.
And did you create, just a quick follow on to that, did you also sort of generate a new research question as you were exploring that? Did you see a relationship between where, say, African American population lives and the diagnosis of, or the death certificate mentioning ATTR as the cause of death? Did you see a relationship there?
Yeah, so that was an important point. So, and that's probably another key finding of our study, was that we saw that death rates were higher among African Americans, and you could hypothesize that areas that have high proportion of African Americans, such as in the South, that they would have higher reported amyloidosis mortality rates as well. And we saw the exact opposite. So those areas where kind of the highest risk individuals actually had the lowest reported mortality rates. And so that mismatch, I think, further highlights that there's not only a geographic disparity in terms of diagnosis rates, but also a racial disparity. And so, I think this is where we'll probably talk about this more, but I think in order to tackle these big problems, you need to have collaboration across various sectors. And so, I think this study kind of identified a group of patients or group of people in regions where there are higher vulnerability to this disease. And so working with medical centers and policymakers in those regions, I think, would have the highest impact. And so, that's kind of where, one of my hopes from this type of research is that it can spur that conversation with other stakeholders to make positive changes.
Thanks. I want to, you're right, we're going to come back and talk about collaboration more, but I want to follow now on the thread that we've all brought up a few times now about the geographic component of this data and what we can learn from that. So Taylor, I want to start with you here. Can you talk about the relationship between setting, well, the geographic parameters, of the data and what's available to us? We've talked about county level, we've talked about zip code level, et cetera. So the first piece is just talk about some of those geographic parameters, but then talk about some of the data issues associated with the geographic settings.
Yeah, sure. So in indices, where we are aggregating, the CMS data, we probably have 5 or 6 different geographies by which you can, aggregate the data. And obviously being able to aggregate at the zip code level is really important to us, in that you can get more local and a more granular picture of what's happening. One of the limitations that comes with that, particularly with the CMS data set, is that, they have a suppression rule in place, and a requirement where if there's any aggregation where there would be fewer than 11 patients showing, we have to suppress that data out of a concern for privacy. So that, while that is a good policy to have in place, it's just a challenge that comes with working at a lower level, obviously respecting the privacy of the patients. But again, having that granularity can be very helpful. One thing in particular I enjoy with so we've created a COVID index that's publicly available. And so we have, one of the things that I like about it, and that I find to be somewhat unique, is that you can view congressional district boundaries, but within that we actually aggregate the COVID data at the zip code level, so that gives you some insight into where inside of districts you're seeing differences in the manifestation of COVID. So having those geographic insights is really helpful.
Thank you. And then I want to talk a little bit about how we see the geographies. So we're sort of talking in very abstract terms about the data and zip codes and stuff, but then how do we see it? What are the visualization tools available to us? And I want to talk to Taylor about that. Yeah, let's start with Taylor on that one too. Stay on Taylor.
Yeah, sure. So yeah, there's a lot of tools, obviously, for viewing the data. And so in addition to the mapping, one of the things when you're working with data is it's much easier to understand if you can visualize it, right? So, we have 5 billion records, but what does that look like? And, the answer is it doesn't look like anything until you sort of find meaning in it. And so being able to map data kind of gives you an instantly digestible, easy to understand view of data. And then so in addition to that, adding other elements like overlaying sites on top of the aggregated data gives you a sense of, okay, here's where these diseases manifest, but here's where we have treatment sites or centers of excellence. And so seeing those in relation to each other is very powerful. And then in addition to that, you start to include, having graphs and charts and making these things where they all interact with one another, and you create a more full picture. And it really can help with the exploration process and the learning process accelerate when you don't have to, query data and look through tables and spreadsheets, but you have something that's very digestible.
Thank you. And I'm going to come to you in a second, Jacob, but Dr. Alexander, did you use a mapping visualization tool that helped you to see kind of where the death records were for ATTR and the relationship to the diagnosis centers of excellence?
Yeah, I mean, that was the central figure in our paper. I think you can do bar graphs and line graphs to look at mortality rates, but to scientific community or lay community, that's still pretty abstract. That's when it really struck us when we did a heat map of looking at the reported mortalities and just overlaid that onto a map of the United States. And then we went to the Amyloidosis Foundation website, Amyloidosis Research Consortium website, to the established amyloidosis centers and just put stars on the map. And so you could very clearly see that places that had more stars had higher reported mortality, or had, in this case, red was kind of higher mortality rates. So the red states had more stars for the amyloidosis centers in it. And so you could you could look at that picture for a few seconds and get that message across. So I think that how you represent the data is really important and really powerful.
Thank you. Jacob, now I want to come to you and sort of this is the context. We've been talking a lot about the structured data, but as Dr. Alexander mentioned, I think Taylor mentioned too, this is all retrospective data. This is all historical data, and it could be a year old, 2 years old, or even more. It does indicate for us where people are that are living with these conditions. But we've also talked about that the community, it gives us some idea of the communities to focus on for whatever our research question is. But the work that you're doing is not going to be retrospective data at all. That's going to be real-time data. So let's talk about community engagement and the ways of using sort of this historical data to drive our real-time initiatives.
Absolutely. I think one great example of that was previously mentioned by Dr. Puckrein. So with the AI HealthNet platform, what we're really doing there is we're creating kind of breadcrumbs for our users as they navigate through these very particular and very easily digestible pieces of information. We're also tracking how they are coming to find these resources geographically and through which service. And so one thing that kind of mirrors what Taylor was talking about from my space is that I can see where people are coming to a microsite geographically, and I can see from which social media campaign they're engaging with. And I can look for discrepancies in where people are signing up, but where are they being exposed? And that's incredibly powerful because that can shape my communications further down the road. And all of that is enhanced by the fact that it's real time. So that's the real innovation and the real genius of AI HealthNet as it expands.
So I'm going to ask you, because a question has popped up in the Q&A. I'm trying very hard to monitor at the same time. Can you just plop in a link to one of the AI HealthNet microsites so that people have an example of what
Absolutely.
that is while we're talking? And then I wanted to go back just a second because I'm not sure we covered it a lot in the earlier talk, just on geography. Did we talk about the data suppression? So I have two more sort of areas around geography. One is on data suppression. And Taylor, I wonder if you could talk about that. What's the relationship between the geography we're studying and the first of all, what is data suppression? Why might data be suppressed? And what's the relationship to the geography?
Sure, yeah. So I think I did mention earlier, the suppression rule that we have from CMS is that at any level where you're aggregating data and you'll end up with fewer than 11 patients, we have to hide that count, that number, out of privacy concerns. So we often see this at the zip code level because that is the most granular geography we use. But this can also come into play in other ways, like when we look at provider data and we want to see the demographics of the patients that they see. Oftentimes we notice that for races, non-white patients, if there's not more than 11 being seen by an individual provider, we don't necessarily get that information in the panel. And so it is a challenge that we face when we're working with the data.
So again, another understanding of that relationship, and maybe a limitation, but the way to mitigate that might be to look at a larger geography. I want to also just sort of touch on the same thing with Dr. Alexander, because you've talked about some of the databases you're using, they go down to the county level. And we did get a question before the session started from one of the registrants around sort of all these other sources of data. So we've got some data like the Medicare data that goes down to zip code level, but a lot of the other data around social determinants of health is the smallest level might be larger than that. It might be county level, or it might be state level, for example. Can you talk about that a little bit and sort of how you match kind of your question with the geography available to you in the data?
Yeah, I mean, I think it depends on, so I'll just say kind of, I'm kind of a disease-based focused person. So, I think for common diseases, say coronary artery disease, you could probably still get a lot of granular data just given at a county level, just given the prevalence of the disease. For me, with cardiac amyloidosis being rare, it's already a challenge to get any kind of county data. So, we're very fortunate to get what we did from the Wonder database. But I think that that's where you have to look for complementary data sources. And so that can be multi-center observational studies, for example, of these amyloidosis centers, maybe picking a range of centers across the country to collaborate, which we have and others have. And so you just have to kind of see what those limitations are. And if you need kind of more granular data, being very deliberate about how you go out and collect that. And a lot of times you have to do it prospectively. There might not be a historic data source that captures everything that you want. So it requires some foresight and yeah, definitely a challenge.
Thank you. So let's talk about, let's go back to Jacob now for some of that ways to gather prospective data. How do we build audiences in the community to sort of receive the data? Dr. Puckrein talked about that as well a little bit. Can you give us some insights and maybe some examples of how we're approaching that?
Yes. So the main feature that has to be implemented there is that you have to make each item very customized to your audience. So you might have several toolkits. You might have several versions of the same communication tailored to each audience. One audience could be very medically focused, and then you have a more lay audience, but it has to be also meeting the requirements of the platform that you're on, and it has to be within the requirements of Twitter, for example. So you have to meet the requirements of the length for a tweet, but you also have to meet the requirements of it being comprehensive for your audience, and that's going to vary based on who's looking at it. One good example of a campaign that we did this with is with the Cancer Care Continuum publication via the Diverse Cancer Communities Working Group. If I could share my screen briefly.
You go. While you're doing that, I'll put some links in the chat.
Thank you. So when promoting the Diverse Cancer Communities Working Group's publication, we wanted to make sure that all of the stakeholders within the toolkit, so that's the authors and the partners that were contributing to the manuscript, had a very clear understanding of where they stood in terms of their performance and their contributions to the promotion of their work. And so one way you can do that that's kind of unconventional is by treating them in this network analysis. So each of these nodes represents an author or a Twitter user. Many of them are authors, but it's just any Twitter user that happened to use the hashtag Cancer Health Equity on the day that I pulled the data. And that gives a very clear picture of what the community of discussion was around the time that we were promoting this manuscript. And interestingly, we had people who said that they were cancer survivors and they were interested in reading more about the literature, and that drove the conversation further. But we were able to really see some of the insights when it came to real-time insights from a dashboard. So I created this dashboard to support the promotion of the publication in real time. And this dashboard shows the number of followers of the particular contributor. So in this case, Twitter user. It has to refresh, I apologize. There we go. So each of these dots represents a particular user on Twitter, and then we map the number of followers that they have. So we have a very clear picture of who are the bigger players in promoting this concept and this topic. At the same time, this is really developed for the users of the toolkit so that they can kind of cross-pollinate existing content. All of the actors can come down here and open a particular tweet and retweet it or engage with it. And it really creates this single source of truth so that everybody knows where they stand and they're all kind of held accountable for their contributions as the campaign grows. That really moves back into something that Taylor was bringing up, which is that our analysis of data often has this component of making things more egalitarian. By doing this, we're making this campaign more egalitarian for everyone that wants to engage in it. They have a very clear understanding of where are we falling behind, where are we really excelling, and how do we mitigate those limitations. So that's kind of an unconventional approach, but it really proved to be successful in our promotion of a manuscript.
Thanks, Jacob. Oh, is it okay? I'm gonna interrupt you there because we've only got a few minutes left. I want to get to more of the audience Q&A, but you talked about taking accountability, personal action and accountability. So we talk a lot about sort of the structured data in the abstract, and we've talked about the real time that you need to start to develop on your own through community engagement and targeted initiatives. But what is the personal accountability that this kind of that analyzing data, this type of research can lead people to? So Dr. Alexander, I'm going to start with you. You talked about the ascertainment bias and physicians not maybe being aware to put the actual cause of death in there. So what's an accountable action that needs to be taken to help address ascertainment bias?
Well, I mean, I think it requires a lot of education from the patient level and the physician level. You know, there's a lot of groups interested in this in amyloidosis, for example, in academia, patient advocacy, as well as pharma companies. And I think that that's ultimately what will help move the needle in terms of understanding or improving awareness and diagnosis. So, I think from a research standpoint, you're kind of, the data you get is the data you get. So, I think that for example, the Wonder database will always have that inherent bias, which is fine as long as you recognize that limitation. But kind of at a just a societal level, how to improve ascertainment bias, I think it's a widespread education effort.
Thank you. And we're accountable for that, right? We need to know how to develop those education initiatives and work with the right stakeholders. So there's your beginning theme of collaboration again. Taylor, can you talk a little bit about an example, say, of an actionable, I'm not thinking of the right word, of an action one can take accountability for doing based on maybe some of the visualizations that we've got? You gave the example of looking at a map of a disease population and then where clinical trial site locations are. So having that kind of visualization, what type of insight can that give us that allows us to design an action that we can take and be accountable for?
Sure, yeah. So, I think if you're an organization that's trying to decide, which locations you want to, locate, say a clinical trial or some kind of a site, being accountable to yourself in that, being able to use a tool like one of the indices to see, how good of a job did we do in locating this site around where are these patients, and, how equitable will the access be to these locations? And so I think that's a really important way that you can say, oh, here's where we've got our current sites, and here's where the patients are, and how good of a job did we do aligning those things. And then another, sort of bias that comes into play, I think a lot of people, tend to have a bias that in their locality, they often, I think, maybe overestimate how the quality of certain things. You ask people the quality of education in their school district, and they think it's really high, but they think nationally not doing as well. Things like that. If you can give them that zip code level, that really localized level data, you can deliver to people. Well, here's the reality on the ground, and here's what it looks like in your neighborhood, and here's the differences between neighborhoods in your city, and you can have local accountability in that way. So there's a lot of different ways that you can come to accountability in the data.
Thank you. So I'm going to go. We've got about 8 minutes left. I want to just check how we're doing on the Q&A. We have put some examples of links. I did my best to put the links into the chat. There was a question about having a link to a microsite and toolkits that we have available. So I think we've answered those questions. Feel free now in the audience to put in some additional questions. We did get one in advance. And the question that we got was, what data sets that can provide insight into quality of care disparities, such as delayed diagnosis by a specialist for multiple sclerosis, rheumatoid arthritis, and cancer patients, delays in commencing treatment, access to innovative diagnostics and treatments. So we've talked a lot about some of those clinical care data sets. Is there anything else we need to say more about the data sets? Hopefully the person who asked that is still on the line. If you've got a follow-up question, you can ask us. What I think another piece of that might be are the social determinants of health data sets that might complement these clinical data sets and help to provide more of a context why there might be a delay in diagnosis for within a certain geography, for example. So maybe we'll start again. I might pick on you a little bit, Taylor, and then go to Jacob. But Taylor, what's a social determinant of health data set that might help us understand, say, more about lung cancer and the type of intervention we might need in a particular geography because of lung cancer? I'm catching you off guard. I know I didn't ask you this question in advance, but I'm just trying to think. We've thought about some of those different data sets ourselves. So if that's not the right one, then what's another example where where you're aware of overlaying a social determinant of health with a different, with a disease.
Yeah, sure. Yeah, and I mean, lung cancer is a pretty easy one, just because, you know, tobacco use obviously is going to probably be a factor that you're going to look at, as well as, you know, poverty and education levels often, you know, correlate as well. And so, you know, there's a lot of sort of known correlations with social determinants of health data.
Yeah, and we certainly know with tobacco use, particularly even now, there's current legislation. I think I saw, you know, the other day, everyone's talking about not just tobacco use, but menthol tobacco use and the legislation around that to address some of the equity issues with lung cancer. Jacob, maybe you could touch on that same type of question, but from the point of view of disinformation. Dr. Puckrein had started talking about we need to crowd out disinformation. And so I wonder if you could touch on that a little bit.
So I think we'll go back to the example of AI HealthNet and kind of its power and what the mechanism that really drives it is that it is such a tight space to get very high quality and digestible information. So it's really this question of breaking through noise. And I think that ties back into something that I brought up earlier, which is that if you're trying to reach your audience and particularly you're trying to get them to do something, you really have to focus on the quality of their actions and the quality of their engagement with the content. So if you're trying to determine some kind of behavioral characteristic, you're going to want to filter out things that are probably considered noise. So I'm going to try to tie that into what Taylor's talking about with lung cancer. If you were to look at discussions about smoking on social media, you'd probably be able to overlay that and find correlations from linguistic insights about language about smoking and the particular uses that people have on social media. You'd be able to probably find relations to health outcomes from something as simple as, you know, a textual output on a social media platform. Again, that could probably also work with education and any other social determinant of health. But that correlation as a tool is something that definitely works for social media outputs as well as more structured data sets.
Thank you. Well, I don't see any more questions from our audience, so I'll put that out last, what is it? Last bell? I'm trying to think of the right term. It's escaping me, but I know you get it in the bar. So anyway, last call, I guess, for questions. But as folks are thinking of maybe that last question, I'm just going to do a little bit of a round robin and ask our panelists, what's kind of one thing you'd like people to leave this session with, thinking about this relationship of trust and data? And I'll start with Dr. Alexander.
I would say be creative, be collaborative. There's lots of stakeholders, lots of data sets. You know, I think we tend to view things in silos, and now it's time to try combining those things and figure out you know, novel ways to answer questions.
Thank you. Taylor?
Yeah, I'll probably just.
We lost you. We lost your audio for a second.
Oh, can you hear me?
Yeah.
Okay, great. Yeah, I'll probably expand on that in that, you know, collaboration is super important because there's so much data. And, you know, NMQF cannot, you know, nearly even begin to scratch the surface on all of the, you know, things that we can find in the data. So it's extremely important that we have people working with us, engaging with us in our indices, giving us feedback, you know, being creative, and then, you know, bringing their own data sets and asking their own questions and just being curious on their own, because, you know, people will learn from us as an organization and we'll learn from them. And, you know, that's really the only way to get to the place that we know we all want to be. So.
Thank you. And then Jacob, I'll let you wrap it up for us.
I think that the real power in collaboration is the combination of using multiple perspectives in concert allows you to unlock insights that you wouldn't find if you had a more narrow or more focused perspective. So again, looking at social media as a a way to connect to more structured data sets. It seems kind of unconventional, but there are going to be questions that you're going to ask from a social media perspective that you would never think to ask from a more structured perspective, just because of the inherent biases you come into the space with. So I think that, again, AI HealthNet addresses that in a very succinct way, because everything is more digestible. It's also more easily replicated. It's also more easily engaged with, and that generates more salient questions that get to more useful insights.
Well, I'm going to let you have the last word almost, but what I heard as sort of our talking points leaving the conversation are: be collaborative, be creative, be curious, and we'll get there with all of the data that's out there. I want to thank our panelists certainly for sharing your experiences and your insights and your examples with us. I want to thank our audience for hanging in there with us as well. And I want to wish everyone a happy first almost summer Friday afternoon. Bye-bye, everybody. Thanks again.